Good evening, everyone. I'm Tony Segreto, and once again, so very honored to be your moderator for tonight's In the Know Town Hall. We welcome all of you. Tonight, we're going to focus on a topic that is top of mind for so many of us: aging, orthopedic health, and mobility. Think about it. Every day, and I do mean every day, we put our bodies through extraordinary stressors. The very act of living our everyday lives increases the potential for physical injuries of all kinds. Add in the natural process of aging, and we're sure to suffer from musculoskeletal issues that significantly impact our quality of life. Everything from osteoarthritis and osteoporosis to bone fractures and dislocation. So here's the question. How do we manage the slow, degenerative orthopedic conditions that affect our bodies as we age? And what are the latest treatment innovations to get us up and moving again? Well, tonight's panel of experts will lead us through the vast topic of orthopedic health and the aging body. We are so truly fortunate to have with us tonight the best and brightest of UHealth, walking us, no pun intended here, but walking us through scientific challenges and advances in the field. The panel is led by Dr. Francis Hornacek, chair of the Department of Orthopedics. He's also the co-director of Orthopedic Oncology at Sylvester Comprehensive Cancer Center and the Center for Chordoma Care at the University of Miami. And he's the division chief of Orthopedic Oncology at the Miller School of Medicine. Also with us tonight, Dr. Victor Hernandez, chief of the Division of Arthroplasty and Adult Joint Reconstruction. Dr. Hernandez is also the research co-director and associate professor in the Department of Orthopedics at the Miller School of Medicine. And Dr. Thomas Best, he's going to add his expertise as vice chair of research in the Department of Orthopedics. He's a professor of orthopedics, family medicine, biomedical engineering, and kinesiology at the Miller School of Medicine. Dr. Best is also the director of the Primary Care Sports Medicine Fellowship and team physician for the University of Miami Intercollegiate Athletic Department and the Major League Baseball Miami Marlins. Also joining us tonight is Dr. Thomas Temple, co-leader of the Sarcoma Site Disease Group at Sylvester and professor in the Department of Orthopedics at the Miller School of Medicine. As you can see, and we say this so often, and it's applicable tonight, the Mount Rushmore of world-class panelists of experts and the innovators in their field. Now, before we get started, let's go over how you can participate in tonight's conversation. After Dr. Hornacek has delivered his opening remarks, all the panelists will answer the questions that you've submitted over the last few days. But you're also going to have the opportunity to submit your questions during the program live. For those of you who have been with us before, you know how it works. For those of you who are new, look at the bottom of your screen. You're going to see a Q&A feature there. You send us your questions through that Q&A feature. All the questions submitted will be anonymous, and we promise we're going to get to as many of them as we possibly can. And trust me, we have a lot of questions already tonight. So let's get started. We have a lot to get to. We want to bring in Dr. Hornacek to set the stage as we move forward in tonight's conversation. And Dr. Hornacek, we cannot thank you enough for taking the time to spend with us tonight.
Thank you very much, Tony. I'm delighted to join you. I'm also thrilled to represent the Department of Orthopedics, the Miller School of Medicine, and the extraordinary faculty, staff, and physicians we have. They are leading the way in orthopedic research, clinical care, education, and service to our diverse communities. As you mentioned, Tony, musculoskeletal issues become increasingly common as we age and bring on limited range of motion, acute and chronic pain, and traumatic injuries. We also manage patients who are dealing with significant mobility and pain issues from a number of factors, including, like you mentioned, osteoarthritis, osteoporosis, bone fractures, dislocation, and other disorders. Our mission and calling at UHealth and the Miller School of Medicine is to help our patients manage and reduce the impact of these orthopedic disorders. We're also at the precipice of major breakthroughs that will simplify and change the way bone and various joint disorders are treated and prevented as well. We'd like to prevent as many as we can. Tonight, as we answer your questions, you will hear more about the latest research, as well as innovations, and expand treatment that we have to help our orthopedic patients. Orthopedic conditions affect patients of all ages, from the very young to the very old. While my colleagues on this panel can answer most, if not all, questions on aging and orthopedic health, they do have their areas of expertise, as mentioned by Tony. Dr. Hernandez can help us understand advances in joint preservation and replacements. In fact, we are one of the few centers nationwide conducting clinical trials on digital devices worn by patients. They are sort of attached to the leg or the skin that he'll tell you about. And they're placed after total knee replacement to improve our rehabilitation outcomes, as well as reduce barriers to recovery. Dr. Best, as you heard, will lead us in the area of common sports injuries and their long-term effects, including post-traumatic arthritis. And together, Dr. Best and Dr. Temple answer us in joining the questions about breakthrough research in orthopedic care. We also have much to share on the future of genetics, genomics, regenerative medicine, and the use of orthobiologics that many of you have questions about, like stem cells, PRP, and tissue banking. We'll also explore the use of medical knowledge and technology, including those of robotics. Robotics is a little bit different in the knee or hip as opposed to the Da Vinci and other places. And tissue, and as well as artificial intelligence has helped us with many things these days. Each year, our doctors provide care to more than 70,000 outpatients. We see about 9,000 orthopedic emergency room visits and perform approximately 8,000 surgical procedures. Our research advancement and clinical care innovations are informed by the experience gained through our patients that are very important and precious to us. We learn a lot from you. And sometimes we learn more about you than we do from the patient-reported outcomes that you'll hear about. We are excited to share with you what we know. I hope we can answer all your questions as mentioned. And Tony, thank you.
Thank you, Dr. Hornacek. We are going to start because we do have so many questions. We are going to start with our first one. Dr. Best, we welcome you. Thank you for being with us. I know you have a busy schedule. So the question goes like this: is there evidence that exercise improves or delays the aging process?
Well, thanks very much, Tony. First of all, I prefer not to think of it as aging, but maturing, as one of my 95-year-old patients told me one day. And secondly, I think the goal in life is to die young as late as possible. So with that philosophy in mind, we do know very solidly that exercise not only delays the aging process, but improves the aging process. Exercise is probably the most powerful medicine that we have, and yet it's probably the most underprescribed medicine in our healthcare system today.
Thank you, Dr. Best. Dr. Hernandez, we welcome you. What options do I have before considering a joint replacement? I know there's a lot of people who ask this question of you.
Yeah, it's very important. As Dr. Best said, exercise is one of the key factors to prevent damage to your joints, because exercise helps you losing weight, which is the second most important things that we can do to prevent joint replacements. And then after that, we have multiple options, starting with physical therapy, we have plenty of places that hit physical therapy at that can help you rebuild your muscles. It's important to have muscles around the knees because it will take pressure out of your knees or out of your hips or even your back. And then we can start with orthobiologics that Dr. Best probably is going to touch a little bit more about them. Injections that goes from just cortisone injections to plasma to stem cells, going into visco supplementations. And there's multiple options and surgical options before considered joint replacement.
Thank you, Dr. Hernandez. Dr. Hornacek, can a whole joint be transplanted?
Yes, a very good question. Actually, whole joints have been transplanted, but there's a problem. I mean, in terms of, I know knee transplants, both sides, the femur and the tibia, as well as in the elbow, where the proximal and distal, the upper and the lower part have been transplanted. The problem is when that's happened, there's a lack of proprioception or a lack of some of the normal sensation that you have around the joint. The joint forms like what's called a Charcot joint, and they deteriorate relatively quickly. So that's certainly a problem.
All right, Dr. Hornacek, thank you. Dr. Temple, we welcome you. How are biologics being used to improve outcomes in patients with bone and soft tissue tumors?
Well, Tony, we've been using biologics for decades. We've been replacing bone and cartilage with great alacrity. More recently, we've added a stem cell, and the stem cell that we've used is something we call the Miami cell, which is derived from an adult but has extraordinary regenerative capacities, and we've been able to accelerate bone and cartilage healing with the use of this stem cell.
Thank you, Dr. Temple. Dr. Best, we talked about how exercise delays aging. What about before surgery? What can I do to improve my outcome after surgery?
Well, there's probably three really important points here, Tony. The first is going to sound a bit repetitious, as Dr. Hernandez mentioned, but we call it prehabilitation, right? And that is going into surgery in your optimal physical condition, not only in terms of your muscle strength, but also your cardiac function, your lung function. All of these parameters can lead to a better outcome. Secondly, let's not forget the importance of nutrition. It's not something that we typically think about, certainly when we're younger, but as we age, we know that nutrition is very, very important to our overall health and certainly recovery from surgery. And then finally is the importance of sleep. We've learned this certainly through our elite athletes, that performance is really tied to sleep and sleep patterns. And so those would be the three factors that if we can optimize prior to surgery, regardless of what kind of surgery it is, will lead to a better outcome.
That's wonderful, wonderful advice. Dr. Hernandez, we have a two-part question for you here. First part is, how long will it take to recover after a joint replacement? And how long will a joint replacement last? And will I have limitations afterwards?
Yeah, two important questions, Tony. The first question, we have done a lot of advancing joint replacement. Nowadays, we have the ability to have robotics. We have technology like wearable devices that improve the recovery time. We used to see people 5 years ago recovering will take 3 to 6 to a year, but nowadays we have decreased that to around 6 weeks to 8 weeks of recovery. That's the main recovery of the surgery. After surgery, because we work on the bone, you're going to continue progressing and recovering some of the atrophy of the muscles that you have lost over a period of time, and you will see improvement onto a year after surgery. But normally the main period for recovery will be from 8 weeks to 3 months. Most of the people return to work and normal life after 3 months, and some people take a little longer, some people take less. It depends on your age and activities that you do in daily living. How long will it last? That's a good question, because it depends on two things. The materials that we use today should last in between 20 to 30 years. And it depends on your age, your weight, and your activities. So we do surgery to get you back into the game and get you back in normal life. So we want you to become active. And after you become active, the goal is to lose some weight. So you decrease the weight and you increase the longevity of the implants. But if you continue gaining weight, doing a lot of high impact activities, sports, that decrease a little around 20 to 25 years.
And Dr. Hernandez, I have to ask you, is there an age limit for a successful outcome?
In average, the ideal age is around 60 to 70 years old. But with the new technology, the new materials we're using, better implants, we start seeing more and more young people with post-traumatic arthritis having benefits of joint replacement. So I have done, for different reasons, I have done joint replacement in very young people, including in the 20s, onto people in the hundreds. My oldest patient is 104 years old, and she's still happy and active.
100? Did you say that? I did hear that correctly, right? 104?
104, yes.
So if you're older than 70, which obviously she is, and you're active, you're going to get a pretty good outcome.
Yes, and one of our benefits at is that we have the support to optimize the patients toward the surgery. If a patient has medical conditions, we have cardiologists, we can optimize them towards the surgery. So this is a very elective surgery. There's no an emergency to go into the surgery. So we can take the patient, we can analyze the patient, and we can optimize this patient. So we see age has changed with time. And people have become more active, and they live longer. So people are reaching out to us to try to help us going back to activities of daily living. So age to me is not a limit. It's the mental part is the one key here.
Hey, that's great, Dr. Hernandez. Thank you, sir. 104, my goodness. Dr. Hornacek, do tumors occur more frequently in our bones as we age?
Thank you, Tony, for the question. Tumors in the bone can occur at all ages. Actually, I've operated on and now that Victor mentions over 100, I've operated on a few patients over 100. But I've also operated on a 7-day-old with a tumor. And the tumors that occur in bone can both be benign, non-cancerous, and cancerous. And actually, the benign tumors outnumber the cancerous ones. But when they occur in the bone, they're called primary tumors of the bone. And they occur, many in the young, like osteosarcoma, which is a tumor of bone. It's a malignant tumor. But as you get older, a more common tumor would be a chondrosarcoma in bone, or there's a secondary peak of osteosarcoma in, say, Paget's disease. But what's more common in primary tumors in bone is metastatic disease. So as we get older, the chance of, say, developing a prostate cancer, a lung cancer, a kidney cancer, or breast cancer, finding that in the bone is something that will happen. Those tumors have a predilection or somehow home themselves to bone, so that you will see those as patients get older, and that's probably more common than a primary tumor. So it's one of the things we look for. And we treat them somewhat differently.
I bet. Dr. Hornacek, thank you. Dr. Temple, what are some of the new diagnostics and therapeutic strategies for patients with sarcomas?
Well, Tony, it's a rare disease, and it's best managed in centers that have special expertise in diagnosing and treating. We're able to basically see a patient in the office at this point in time and do a needle biopsy and sort of accelerate the diagnosis from days to minutes. One of the things that we're working on in the lab is looking at patients through blood tests where we can actually measure microRNAs that are excreted by tumor cells to allow us to basically make this diagnosis from just a few drops of blood. On the therapeutic side, I say that, I hope I wake up one day and I'm out of business because I don't have to do these terribly large operations on people. But one of the things that we're looking at are basically taking natural killer cells and modifying these natural killer cells genetically and targeting them to sarcomas and actually wiping tumors out, just using the body's normal immune system. So these are just a few of the things that we're looking at in terms of changing the face of therapeutics in patients with this rare disease.
It's just so remarkable what we can do now. Dr. Best, we just had this sent to us, and the question goes like this. As an athlete who can no longer flex my 2 big toes due to having 0 cartilage left in them, I would like to know if there is any hope or anything I can do. I'm chronically in pain, as in even walking bothers me and it hurts so bad, but I still continue to do my athletics, which includes weightlifting.
Thanks, Tony. And that's that's one of the biggest challenges that we face, not only in sports medicine, but in orthopedic musculoskeletal medicine in general, right? And that is addressing problems related to cartilage, which, as we all know, is the material that lines the joints. We all get a certain amount of it. And over the course of time, whether it's through injury or quote unquote wear and tear, that this cartilage can wear down. That's one of the areas that's a big area of focus for us here at the University of Miami in terms of regenerative medicine, is really trying to understand, can we in fact regenerate cartilage? There's a lot of exciting work that's been done in the laboratory. Its translation, though, to patients or humans like all of us this evening has been, at this point at least, not real successful. That gives us something to work for in the future. There's certainly hope. The other tissue that we think frequently about is the meniscus, right, which is the shock absorber of the knee. And again, we face the same problems. These two tissues have poor healing potential. If they're damaged, we certainly try from a surgical standpoint to preserve as much as possible. I think moving forward, as Dr. Temple said, though, there's a lot of exciting work that's is going on right now, particularly in the area of genomics, and trying to understand through, for example, what's known as microRNA, which are these little molecules or signals that our bodies produce. Can we understand more about osteoarthritis, for example, and the different perhaps subtypes or phenotypes of osteoarthritis?
Thank you, Dr. Best. Yes, Dr. Hernandez.
Yeah, I will add something about what Dr. Best was telling. One of the key factors here, maybe this patient is too late already and has a stiffness and lost mobility because it's full bone on bone. Small joints like the big toes or the fingers are a little different of the big joints like a hip or a knee replacement that we can do replacement pretty easy and recover pretty fast. In the small joints, it's a little more difficult. So one of the key factors is look for help before it's too late. So if you feel you're losing motion, you're having troubles, you have pain, this is where orthobiologic or all these injections and regeneration can act. Sometimes when you lose and the joint is already too stiff, maybe it's too late for this to help. And then we have to look for surgical options, which there's a lot of surgical options also that we can discuss.
Thank you for weighing in on that, Dr. Hernandez. Dr. Hornacek, what is the value of patient-reported outcomes, also known as PROs?
Yeah, so patient-reported outcomes are very important. They are generated by the patients. And there's a series of validated questions that are then answered. Frequently when somebody comes to clinic or something like that, they'll be handed a tablet, they answer questions. But what it tells us, we learn from the patients about what's important to them and how they feel, not by our assessment.
Thank you, Dr. Hornacek. Dr. Best, this is such a major issue for the older generation, falls. It's a major problem as people age. And the question that was sent in earlier this week was, what can I do to decrease my risk when it comes to falling?
Thanks, Tony. That really is a key question, and one that we could spend the entire evening talking about, of course, right? Because there's a lot of factors that go into people falling, all the way from how they hear, how they see, of course. From a musculoskeletal standpoint, orthopedic standpoint, we really think about strength, right? So having adequate amounts of muscle strength, particularly in your lower extremities. One of the areas that we're learning a lot more about is the hip and core and the importance of those muscles in the central part of your body, right? Because they really are the transfer zone. We know about this from our days in athletics, where somebody who's a baseball player, for example, if they don't have good hip or core strength, that's going to affect their motion, for example, when they throw a baseball or a runner. And so if we take those concepts from the athlete to the everyday person, which is really just an athlete in a different form of training, if you will, then there's a lot that we can learn, particularly, again, centralized around this concept of muscle strengthening and hip and core strengthening.
So doing exercises to strengthen the hip and core obviously become extremely vital.
Absolutely. Again, just another plug for what is known as exercise is medicine.
Good point. Well done. Dr. Hernandez, statistically, how often do pins and screws break through the bone after repairs are finally made?
Yeah, it just depends. If it's secondary to trauma that we have placed plates and screws, normally if the fracture heals, we shouldn't have any problem. If the fracture hasn't healed, then if it breaks the plate and the screw, it's secondary to fatigue of the metals, which is terms that we use when the fracture hasn't healed. And that is, it depends on every patient. On joint replacement, we no longer use too many of the screws, only on the hip sometimes when we have patients with severe osteoporosis to hold it in place, but those screws is very unoften. And joint replacement normally doesn't fracture or have any problems with it.
Thank you, Dr. Hernandez. Dr. Best, we're going back to you. We just had this sent in. Is PRP helpful in plantar fat pad atrophy?
Thanks, Tony. So I'd start off by answering that question. Remember what PRP is. What we do is we take your blood, usually from the elbow joint. We then spin it down and we are left with what are called the platelets. And platelets, when we all went to medical school, were things that were elements of the body that just helped with clotting. So if you have a low platelet count, you cut yourself, you have problems with bleeding. But we've come to learn over the years that platelets have a lot more than just a clotting factor, right? They contain many of these what are known as growth factors that can promote healing of a variety of tissues. And certainly in the orthopedic area, this has become a very exciting area. The indications for PRP are vast right now. I think that unfortunately the science may be a little behind. We do know, however, that in the last couple of decades, its use in problems such as arthritis that Dr. Hernandez mentioned earlier. There's an increasing amount of literature, even comparing, for example, PRP to stem cells and suggesting that PRP may be more effective. As far as other tissues in the body, specifically to this question, that's an area that I think is still under investigation and really needs to be looked at further to see if, in fact, we can promote. Once that fat pad atrophies, it's very difficult to regenerate that particular tissue.
Yeah, I can only imagine. Dr. Best, thank you. Dr. Temple, what kinds of procedures are available for young children with malignant tumors of the bone?
Well, since medical therapies have become so successful in treating children with malignant tumors of bone, the onus is on us now to preserve function. In doing so, we try to preserve the joint and the growth plate so that the child will be able to grow in a normal fashion. When we can't do that, we can actually remove the joint and the growth plate and replace it with an implant that is able to grow just by using electromagnetic frequencies. So we can in a controlled way, lengthen that child's lower extremity or upper extremity in the office with just an electromagnet.
It's fascinating what can be done now, just listening to all of these different aspects that you can use in surgeries or rehab. Dr. Hernandez, what percentage of chances do I have to regain my mobility after 2 knee surgeries?
Yeah, a well-done knee replacement should give you around 0 to 120 degrees of flexion. That's in average after knee replacement. And that depends on a couple of things. Depends on how bad you get into the knee replacement. If you have lost a lot of motion, it's more difficult for those patients to bend or have more mobility on those. And that's very important for the post-operative care, because what I do is 50% of the process. The recovery, the physical therapy, the patient's willing to recover, and the nutrition and the activities that the patient perform after surgery, it will depend on mobility. Most of our patients, after 3 months, they are full back into recovery, and they have around 100 and 125. Some people reach out up to 130, but normally after 100 degrees of motion, you can perform any of those of your activities of daily living. On the hip replacement, people most often will gain more motion that weight they have lost over a period of time. And it's key for the physical therapy to continue over a period of time to recover your motion. But most of the people return to normal life.
Thank you, Dr. Hernandez. Dr. Hornacek, excuse me, what kind and what can be done to address cervical disc chronic pain?
Thank you. The first measure is probably conservative, but you need to make sure that they probably, if they have a disc that's impinging on the spinal cord or something like that, an MRI will, in imaging studies like an X-ray will probably be done. Also need the first measure is probably conservative, unless there's some problems with even if they have numbness or something in their upper extremities, some of those types of symptoms, we'll still try maybe a conservative measure before putting them through surgery. But it depends on the etiology of the pain and how many levels to it may encounter.
Thank you, Dr. Hornacek. Dr. Hernandez, I have osteoarthritis in one finger. It was sent in to us, and I'm unable to bend it. Are there any exercises I can do to gain mobility in that finger?
It's pretty close to the question about the big toe. So the longer you wait for damage on your joints, it's the worse that we can recover from it. But if you still have motion, simple exercise like one of those stress balls that you can do, it will improve some of the motion. Also, a good exercise is to put the hand inside warm water, and you can do at the end of the day a couple of exercises, open and closing the exercise. There's a lot of treatment we can offer with our hand specialist. It depends also if you have trigger fingers, that's the reason why you can bend your fingers. So there's multiple options we have to offer with injections. Also, we can improve some of the cortisone injections, and there's a lot of new technology that our experts in hand surgery can help if you want to increase your mobility of your fingers.
Thank you, Dr. Hernandez. Dr. Best, we just had this sent in to us. Another person writes, I have severe osteoarthritis in my shoulders, including other pathologies. I've been a swimmer my whole life. I miss swimming. And the question is, how effective is regenerative therapies such as stem or plasma at giving me more time to do exercise that I enjoy?
Thanks, Tony. I guess I would start out by saying that the shoulder, in a relative sense, we know much less about the shoulder than the weight-bearing joints, those joints being particularly the hips, the knees, and the foot and ankle. And in fact, it may be a different environment, right? Because it's not a true weight-bearing joint. That said, there's more to that story, of course, than just looking at the joint and the amount of arthritis. You need to know, for example, what the rotator cuff looks like. We see a lot of patients who have osteoarthritis of the shoulder or glenohumeral joint, and there's a very different outcome based upon whether their rotator cuff muscles are functioning properly or not. Interesting that you would ask the question, though. I had a I would say, very young person in the office a couple months ago. She's a former collegiate swimmer. She's now only in her early 40s, and she has severe osteoarthritis of both shoulders. So the question is relevant, and she asked me what we could try. And I said, well, here's what we know, right? We know that exercise is important. Her specific question regarded PRP and its use in the shoulder. As Dr. Hornacek mentioned earlier, I think that all of us who've been in this business for a while realize that patients can teach us a lot too. So it forced me to go to the literature to see what was available, for these particular kinds of patients. I could find just a few case reports suggesting that PRP may work. We did try it. Our chief musculoskeletal radiologist, Dr. Jose, did the procedure about 6 weeks ago now. She reports decreased pain in her shoulders, and she's got improved range of motion. So there's hope on the horizon. That's one particular case, of course. But again, I think we need more time to understand more about the shoulder. It's a very different joint than the weight-bearing joints that we've talked about earlier.
That's fascinating. We'll have to revisit you in about 6 weeks to see how she's doing after that, because in 6 weeks to get that kind of result is pretty amazing. Dr. Hornacek, we just had this sent in for you. Which exercises are best for orthopedic health as the person ages over 70?
Well, that's interesting because, a lot of the exercises we do are weight bearing, but there's more and more work on rehabilitation of people who've been injured in non-weight bearing situations, right? So one of those is in a pool, right? But they even have a treadmill now, and that has been set up for some people that have non-weight bearing. So you range the joint, but you don't have weight bearing. So those are some of the most advanced techniques. So pool obviously is a great place. You access one, and a treadmill like that. But if you're not the lower impact exercises, riding a bike is also one of those, isn't quite like a pool and things, but those are the things that are good. And like Dr. Best said, core strengthening is very important in rehabilitation.
What about just regular everyday walking? Picking a spot in your neighborhood or whatever.
It's also very good. It's also a good place, good time to talk to your partner or somebody you want to discuss something with. So yes.
Well put, Dr. Hornacek. Thank you. Dr. Hernandez, how common is it for a successful total knee replacement to exacerbate other issues such as spinal stenosis or lumbar arthritis, and what can be done to prevent that?
Yeah, so during recovery in total knee replacement, normally we go from surgery into the use of a walker, and then we try to transfer from the walker into a cane within 2 weeks to 4 weeks, because the use of a walker can exacerbate lower back problems. So we try to expedite on people who comes a little late for surgery and have multiple joint involvements. We try to expedite to get them out of the walker into the cane. If we know in advance that people have back problems, we try to prevent certain exercise after surgery, and we try to expedite them in the recovery time. So there's a lot of things we can do to prevent that. Most of the time, after a knee replacement or a hip replacement, a lot of the lower back issues will improve, but that will take in between 3 months to 6 months. So people that has knee problems or hip problems, what happens is they compensate with the lower back, putting more weight than normal. And when they recover from the joint replacement, they will feel some improvement on the lower back as well.
Thank you, Dr. Hernandez. Dr. Temple, we would like to know what the non-steroidal options are for disc compression in the lower back.
Well, non-steroidal anti-inflammatory medicines are part of the regimen for the treatment of discogenic back pain. But one of the important things that we've developed recently is a product where we actually take the nucleus pulposus, which is the liquid center of the disc. We freeze dry it into a solid form, micronize it, and then add it to a stem cell that we get from the end plate of the vertebra. We then can inject this into a diseased disc, and we can reconstitute the disc, increase the vertebral height, and more importantly, diminish pain. And as we follow this phase 1 clinical trial out farther and farther, it seems as though this result's very durable. So I think that this is not going to be obviously the end of be all for discogenic pain, but I think it's a very, very good strategy going forward and relieving a lot of these young patients with disabling discogenic pain.
Thank you, Dr. Temple. Dr. Best, we talked about this with improving our core for balance, but how is there any other things that we can do to improve our balance? And if so, what are those things and how to go about doing them?
Sure. Thanks, Tony. It's interesting how our thoughts on exercise have changed over time. When I was on the President's Council for Physical Fitness for almost a decade, the only thing that we really talked about was cardiovascular fitness, right? And we used to tell people to exercise, whether it's going for a walk, as Dr. Hornacek talked about earlier, you're playing tennis or riding a bike or whatnot. And we'd say 3 to 4 times, 5 times a week for 30 to 40 minutes. Well, what have we learned in the last decade or so? The last report that came out from the President's Council in 2018 for the first time recognized the importance of strength training. And this is particularly relevant for our discussion tonight, right? Because if you really start to look at the data, it's strength training that's going to improve our quality of life, probably improve our longevity because of risk for falls. So if you look at the guidelines now, we talk about the importance of strength training and not just cardiovascular fitness. But if you step beyond that in core and hip, as Dr. Hornacek talked about earlier, some of the exercise regimens that people use and practice, for example, Tai Chi and Pilates, there's very strong data now showing that exercises of those forms will improve balance, which again decreases your risk for falls.
Thank you. You know, Dr. Best, when you were talking about this, I have the whole screen in front of me, and every Dr. Hornacek, Dr. Hernandez, Dr. Temple, they're all nodding their heads yes. And yes, Dr. Hornacek, would you like to say something, sir?
Yeah, I think as well as stretching too, right? Is one of those things where more and more people are doing various types of yoga, because as we tend to get more stiff, right? So I would add that.
Yeah. Okay. Well, exactly. I was about to ask about yoga, and you bring it right up. That's perfect, Dr. Hornacek. Thank you, Dr. Hernandez. This was just sent in. If a hip or knee replacement is recommended, is it better to postpone surgery until you are in a lot of pain, or have surgery sooner? For me, who wrote this to us, I'm medium pain right now.
Yeah, so the myth was let's wait until you cannot anymore. So personally, our group has published data about timing the knee or the hip replacement. Some people wait too long and the recovery will never catch up as normal people. So nowadays we were talking about patient-oriented outcomes. We have data that we can take a score from a patient and say, your perfect timing for the knee or the hip replacement. We have used different patient-oriented outcomes to get to these scores. Also, you don't want to do it too early, because if a patient has medial pain or there's several options, not only non-conservative options, that means non-surgery, but also some surgeries that you can benefit from. For example, if it's a patient on the 40s, 50s, and maybe just have a meniscal tear that has flip over and now has locking problems, maybe an e-scope is a good idea at this point. But if a patient's in the 50s, 60s, that the pain is on the medial aspect or the inside of the knee, maybe it's a good candidate for a partial knee replacement. Or females normally have something we call patellofemoral disease. Maybe it's a patient with patellofemoral arthroplasty. So there's multiple options that we can do before a knee replacement.
Yes, thank you so much, Dr. Hernandez. Dr. Best, this is, I was wondering if this was going to come into us. Does everyone develop arthritis, or is there some way of avoiding this outcome?
You know, if I truly knew the answer to that question, I could probably take Dr. Hornacek out and play a round of golf with him once a week. You know, that's a great question, right? For the longest period of time, again, for all of us on this call as physicians, we were trained with the X-ray, and that's all we really had. We had CAT scan, we had bone scan, but until MRI came along so we could visualize, for example, the meniscus and the articular cartilage, that's really what we were looking at, was the X-ray. Now, interestingly, there's been a couple of studies come out recently that have suggested that you can actually, from the history alone, your ability to diagnose osteoarthritis of, for example, the hip or knee is good, as good, if not better, just by the questions that you ask the patient. You know, it's been estimated, if you look at the data, the recent data that have come out from the National Institute of Health, that if you're over the age of 65, you have a 35 to 40% chance of having osteoarthritis. I actually think that number is really low because, again, we make the diagnosis based upon X-ray. We also know that by the time you see it on X-ray, that disease is probably far more advanced than just the minor changes that you see on the X-ray. You know, to the question, can you avoid arthritis? I think that one of the exciting things that's coming down the pipeline here is that osteoarthritis is no longer simply a single disease. We were trained that it's wear and tear, right? The cartilage breaks down, the meniscus breaks down, and then you have the secondary changes, whether they're on X-ray or not, that define osteoarthritis. Well, we know now, and we're involved with a study where we're looking at what are called phenotypes or subtypes of osteoarthritis. So for example, you may have somebody that has the inflammatory type, or you may have somebody that has the stiffness type. And you may ask, why is that important? Well, what this is probably coming down to is that I think as we move into the future, it's not going to be simply a history and a physical and an X-ray. It may be a blood test where we start to understand more about the biochemistry of that individual's body, as Dr. Temple mentioned earlier, looking at so-called microRNA expression. And we're involved with some of that work here now at the University of Miami. In fact, we're hoping to began a collaboration with our colleagues out in Vail, Colorado at the Stedman Philippon Institute, where we're actually going to start looking at our patients. And this is something I've started to do in clinic. I have a questionnaire, and then I try to figure out what type of arthritis they may have so that we can address questions like supplements, for example. There are hundreds of supplements on the market. And when you talk to some of your patients, they seem to think they work for them. So there must be something to that. So in summary, I think that I don't want to say it's an inevitable disease. One thing we didn't mention is genetics. There do seem to be a group of patients where there's a strong genetic component. I'm sure Dr. Hernandez sees this as well. So I think moving forward, we're going to have a lot more information for our patients in the future and be able to provide better care in terms of the disease we know now as the wear and tear disease of osteoarthritis.
Thank you, Dr. Best. Yes, Dr. Hernandez and Dr. Temple, you both want to weigh in on this. So Dr. Hernandez, we'll defer to you at the moment. I saw your hand first.
Okay, Tony. So just to complement what Dr. Best was saying, and there's another question from the Q and answer about a patient that her mom had double knee replacement, and she now is concerned that she's in their 40s if she's going to have it. So it's very important that people take into consideration genetics is one very important part of, and with all this new research that we are coming out, probably there's something we can do before it's too late for a joint replacement. The other two things that are important is weight and activities. Everything excess is bad. So we see people that were very, very active running marathons who destroyed their knees and their joints, and also people who were very sedentary and they gained so much weight that they put so much pressure on the knees and they destroyed the knees. So it's a combination of both of them. Probably genetics plays a combination, and then being in good shape and being active, it will help to prevent osteoarthritis in the future. And then we have different type of arthritis. We have post-traumatic arthritis, people that has accident, trauma, falls. Those are inevitable, but there's also some research that at the moment of the trauma, if we can actually, our sport team and Dr. Bess and Dr. Kaplan can talk about it, that when the injury happened, it's the point that we can actually affect the recovery of that cartilage, of that meniscus at that time. So it's very important when you have a trauma or a fall to ask for help to the specialties, sports, trauma, or orthopedic surgeon, because at that point, it will be key to prevent further damage.
Thank you, Dr. Hernandez. Dr. Temple, you wanted to add something to this too?
Yeah, I would just echo what's been said. By the time someone goes to see Dr. Hernandez to have their joint replaced, the changes in the cartilage are clear and obvious. But the earliest changes in osteoarthritis really aren't in the cartilage, but in the bone cells that are above the cartilage. And if you could somehow modulate or change those changes that are occurring in those cells, you would be able to alter the course of osteoarthritis.
Wouldn't that be nice? Thank you, Dr. Temple. Dr. Hernandez, this was just sent in to us. After a bad wrist fracture involving the joint and requiring internal fixation, what can you do to reduce your risk of post-traumatic arthritis?
So post-traumatic arthritis, as I say before, it depends on the type of injury, the type of surgery that they have it. On the wrist, it's a little more difficult of every joint because the wrist has involved multiple joints within a joint. And there's multiple small bones that they can die after a trauma. So our hand specialists, it just depends on the type of injury that you have, it can offer different treatments. If the treatment has been a fusion based on the trauma that you have, it's very difficult to convert into a wrist replacement. But if it's a small injury, that their ligaments are injured and is very unstable, the wrist, our hand specialists can offer repair of those ligaments, and some of them can be actually reconstruct those ligaments with different type of graft and ligaments. And if that happens, you get a better stable wrist, and we will prevent further damage in the future.
Thank you, Dr. Hernandez. Every question, every answer just gets more and more fascinating. Dr. Hornacek, what are the newest techniques for operating on spinal stenosis?
Well, first of all, spinal stenosis is a narrowing of the spinal canal, so that's where the spinal cord is present. But you need to know the reason for that narrowing. But in general, with the, as a degenerative, if you have it in one area, like the lumbar area, frequently have it in a cervical area. So you need to know which area is causing the pain. In say the neck, if it's the disc or multiple discs that are pushing on the spinal cord, you may do an anterior from the front procedure. But more recently, and popularized by the Japanese, is a laminoplasty, where they go in from the back, posteriorly from the and open up the spinal canal so there's more room. Some people tend to have spinal stenosis, more than others, and there are various reasons, like I said, that need to be evaluated before you treat it.
Thank you, Dr. Hornacek. Dr. Temple, we just had this sent in. What experimental and clinical research is being done at UHealth that's exciting you the most?
What I'm really excited, I think the most right now is segueing away from stem cells and actually getting the stem cells to differentiate into whatever it is we want to repair or regenerate, and then collecting the exosomes or the exosome contents, and being able to basically take these exosomes and concentrate them, and then use them with various tissues like bone, cartilage, or nerve to regenerate and repair these tissues. So I find that most compelling at this point in time. I think we're moving a little bit away from the notion of just using a stem cell and using the things that the stem cells are making in response to a stress, and using those to regenerate tissues.
Thank you. Just hearing it is compelling. I can only imagine, actually working on it. Dr. Bess, yes, Dr. Hernandez, what would you like to say, sir?
Yeah, no, so with Dr. Temple, that's one of my major goals for early life, is to destroy joint replacement. It's one of the research I have a lot of eager about. One of the things, because a lot of patients ask me about stem cells. Right now, stem cells has become a business because most of the insurance doesn't cover stem cells. So there's a lot of commerciality in this on play. But when you go to a place that is based on research, like or any of the places that really are behind research, stem cells has a future. We're not yet there in terms of osteoarthritis, because as Dr. Temple was saying, we know that stem cells is like a cells that can turn into whatever they want to become. It depends on where you put it on. We're doing research with the sport team also in knowing these cells, knowing what exactly we have to put it on it, and these cells will turn into what we want. For example, if we want a cell to regenerate cartilage, we can tell the cells, these are the markers, you're gonna become this. Or you're going to become bone. When we have non-union fractures, it's a fracture occurs and then the fracture doesn't heal, we can create one of these cells until you're going to turn into an osteocyte to create bone. Or for example, with a vascular necrosis, which is a disease of the hip that the bone died secondary to lack of blood supply, we can regenerate some blood supply through stem cells. The main problem we have nowadays is the environment. Sometimes people that has advanced osteoarthritis and they want to try the stem cells, the environment it lacks of the normal fluid, and these cells will not survive. And that's actually where the research now it's going into, is to how are we going to take these stem cells from the lab and put it on a patient joint and say, let's change the environment, let's take care of these cells so that they become something that can help either cartilage, bone, or etc. But it's pretty interesting what we are going in the next probably 10 years.
Yeah, fascinating. Absolutely fascinating. Thank you, Doctor. And Dr. Best, we had just sent in just a minute ago. Are there any foods or vitamins or supplements that we can take to help regenerate cartilage?
So, You know, Tony, as we mentioned earlier, right, cartilage is not a tissue that heals very well. In fact, has very poor healing capabilities. You know, as I mentioned earlier, we think that osteoarthritis is really not a single disease anymore, that there are multiple what we call phenotypes or subtypes. And again, why is that important? Well, once we can understand more about the molecular biology, we can then design treatments that can be targeting those different problems, right? And supplements may be one of those. Dr. Hornacek mentioned earlier that I'm the fellowship director in primary care sports medicine. And I'm pleased to say that one of the requirements of our fellows is that they publish a systematic review, meta-analysis of a question of their choice. We've been very successful with that over the last 3 years. In fact, all 3 of my fellows have won awards. 2 of them have actually looked at different supplements. In particular, one of my fellows looked at turmeric as a treatment for osteoarthritis and found from a number of randomized controlled trials that it's very effective for particular patients. What we don't know is which patients it's going to work for. And let me piggyback onto Dr. Hernandez's earlier point, because this is a very intense area of focus in our laboratories in sports medicine. And that is, we can do a lot of things with stem cells outside of the human body. We can control the conditions. I happen to believe as an engineer that it's the way we load those cells is going to signal how they behave. So once we take stem cells and we inject it into Dr. Hornacek's knee for his arthritis, for example, what those cells do afterwards, I think is very much affected by the loading patterns, by the exercise patterns. And we're starting to see some of this come into the literature now. So I don't think it's going to be moving forward just a simple injection, but it's also going to be looking at activity levels, physical activity patterns, because that's what's going to signal what those cells ultimately become.
Dr. Best, thank you so much. And I don't know where this hour has gone. I really don't. This just flew by. And Dr. Hornacek, we're going to ask you for some final comments, but I have to ask you, sir, do you have arthritis in your knee?
I do. Probably from running too much in a younger age, as some of you know. But yes, I do, in the medial compartment. So, and I've had amniotic fluid injected into it by Dr. Temple.
Well,
So, anyway.
we hope it gets better, and I'm sure with Dr. Best around, it'll get better real quick. So we would love some final comments before we go tonight, Dr. Hornacek. This has been a fascinating hour, and what a group! Just been amazing.
Well, thank you, Tony. Such a pleasure having you skillfully moderate this important discussion. And thank you all to the viewers. Your attendance and questions are important to us, and thank you for so many of you tuning into this. My colleagues and I appreciate your interest and your continued support. And as the only university-based full-service multidisciplinary orthopedic department in Southern Florida, we are driven to find treatment and cures, as you could see by some of the answers, that make are important for our community and make a difference. The psychological, physical, emotional burden of living with the pain for many of these degenerative problems, musculoskeletal disorders, cannot be underestimated. It gets in the way of life and limits our very potential as humans, our abilities to work, have fun, enjoy the weekends, and so forth. At UHealth, we know this. We do all we can do to provide excellent care and advance the kind of research you've heard about today and really responding to the needs of our patients. What you heard tonight reflects innovation. You've heard a lot about that, passion and commitment, and I thank all Tom, Victor, and Tom, as well as our other staff that helped put this together. Of course, our physicians and scientists could not do this without you, the viewers. Your generosity ensures that we continue to push on breakthrough research, deliver the best treatment options, and support outstanding physician scientists, which are really important to develop in the field of orthopedic care and research. You inspire us to go above and beyond to find innovations and solutions that will make a difference to all of our patients' lives. That's why we're here. Thank you for joining us tonight.
Dr. Hornacek, thank you. Dr. Hernandez, Dr. Best, Dr. Temple, truly amazing. And what's our big takeaway, folks? Exercise, 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 no matter what your age, you can still do it and be active, as Dr. Hernandez said, as a woman of 104. We want to thank all of you for participating in tonight's town hall. And just for a second, think about this. How fortunate are we to have such amazing, passionate, as Dr. Hornacek said, doctors serving our university family and our community every single solitary day. I know I speak for many when I express my gratitude for their continued contributions to not just patient care and research in this field, but community care as well. Please remember that a full recording of this program will be posted online. Look for the link in the coming days. Now, in a moment, you're going to see a survey about tonight's town hall on your screen. Please take a minute. I have taken this survey, and it doesn't take a minute. It takes less than that. It probably takes like 15 or 20 seconds. So please, we would love to get your feedback, because what that will do, that'll help us understand your interest and improve our program. As always, we thank you so much for joining us. We wish you and your family good health. Please stay safe. And remember, it's all about the you. Good night, everyone.